Good evening. This is number 3 in my series on the diabetic eye, and we're going to focus on glaucoma in this video. And before I get into glaucoma, glaucoma is a vast subject. We could spend hours talking about glaucoma. We're just going to focus on a few issues where the diabetic is concerned as far as glaucoma tonight. But before I get into that, my previous video, number 2, diabetic cataracts, and it brought up in the comments section under that video, it brought up some interesting discussions. I had one subscriber that mentioned that she was in a waiting area where cataract surgery was being done, and saw the doctor bring out a patient who had just had cataract surgery done, and he was telling the wife, well, he waited too long to have his cataract removed, and it turned out to be more complicated, and he's going to be in some pain and all that. So she was very concerned that people be warned not to wait too late to get their cataract surgery. And certainly there is something called a hypermature cataract, which there's no reason these days to wait that long to get it done. In fact, you're better off getting it done before it reaches that hypermature phase, because the surgery will go much smoother and have fewer chances of complications. Now, another subscriber noted, and she mentioned that she could remember the day when doctors wouldn't do the surgery until you reached a real mature stage, and that was true years ago. They called it waiting for the cataract to be ripe before they would remove it. They waited a long time. In fact, back in those days, they would wait until you were almost blinded. I mean, you had a long time of not being able to see well. And since most people develop them at a later age, they might not live long enough to get cataract surgery done. And so what has changed in all those years? Well, for one thing, the surgery has improved so much that there's no longer a reason to put off cataract surgery that long. Back in the old days, cataract surgery was a pretty traumatic thing. You would have to be in the hospital for several days. There was a large incision that was made from like the 3 o'clock to the 9 o'clock position, opening half of the circumference of the cornea up and removing the old lens and putting the artificial lens in its place. And cataract surgery back in those days was a big deal. And so they wouldn't do it to somebody's eyes until their eyes were really, really bad. So they actually waited for that mature stage before they would remove it. That's not the case anymore. The surgery has improved to where they don't make this big. With that old big incision, there were a lot of stitches required, and you had to be in the hospital. The recovery time was much longer. It was a big deal to have cataract surgery years ago. It's no longer that way. It's a day procedure now. You go in, get it done, come home the same day. And it's instead of having to make this big opening, cataract surgery went from this big opening down to like a procedure that they would do with only one stitch, and then it went to no stitches. And that was because the instrumentation, the technology was getting better and better. It could be done through what was essentially like the equivalent of almost like just sticking a needle into, instead of making this big incision to stick surgical instruments in the eye to remove the old lens, could now be done through just a pinpoint. And I won't get into all the specifics of the surgery now. Done through such a minute little hole to it. And in fact, if you wait till that hypermature stage, it makes it more complicated with the new type of techniques that they have and all. So it's a more trauma to the eye than it needs to be these days. all cataract surgery used to be traumatic to the eye back in the old days. These days, don't wait too long to have your cataract surgery. Generally, what happens today is if the cataracts are interfering with your day-to-day activities, such as being able to get your driver's license renewed, then they go ahead and do it if you're still actively driving. But let's get on to glaucoma. Glaucoma is a huge subject, and there's no way I can cover everything about glaucoma in one little talk tonight. I try to keep these talks less than 15 minutes, and there's no way I can do justice to all that there is to know about glaucoma. I just want to talk about it in terms of diabetics. And there's a number of things when a diabetic comes in for their yearly exam that we check, and checking for glaucoma is definitely one of those things. We check everybody for glaucoma because, like I said, with cataracts, non-diabetics can get cataracts, non-diabetics can get glaucoma. So we check everybody for glaucoma, we check everybody for cataracts. But it's definitely on the list of things that we're concerned about with diabetes. Let me give you a list of risk factors for glaucoma. Glaucoma is more common in persons who are older age. It is another one of those aging things similar to cataracts, although there are types of cataracts you can get at a younger age. But the majority of glaucoma is are older age patients. It's also more prevalent in African Americans and Asians and also Native Alaskans. It's also more of a problem for people who have a family history of glaucoma. It's also more of an issue with people having diabetes, heart disease, or high blood pressure. So again, this is one reason we're concerned about it with our diabetic patients, and we're going to do a real thorough eye exam on all of our diabetics, and glaucoma is definitely one thing we're concerned about. Also, people who use steroids long term, and not just a short term. A lot of people have to take steroids for a real, short term, few weeks or so for some inflammatory condition. But people with chronic inflammatory conditions that have to take steroids for months and months or years and years, we're definitely concerned about glaucoma in those patients because that is a side effect of long-term steroid use. Also, people who've had a head injury or like a tumor in the eye, they could be more susceptible to glaucoma. So anyway, we test for glaucoma by testing the pressure in the eyes, and then we also look at the optic nerve head to see if there's any damage there, because that's what happens. Glaucoma is an increased pressure inside the eye. Let me show you my poster again to kind of help explain about glaucoma. So far we've been talking about the lens here in the front of the eye. Again, this is the cornea. This is the iris that gives your eye its eye color, and then this lens that sits behind it. We talked about that in the first and second videos, and it's particularly important with cataracts. That's where cataracts form. But for glaucoma, what happens is there's a fluid that fills the front part of the eye called the aqueous humor. It's a filtrate of the blood. It comes out of the blood supply to the ciliary body, which is muscle tissue back here just behind the iris. Aqueous is formed there. It comes through the pupil. The pupil is an opening in the iris, and it drains out in the angle of the eye. This happens 360 degrees all the way around. I'm showing it like it just goes down. It goes up and it goes all directions. It's 360 degrees. But this is called the angle of the eye. And the rate of production should equal the rate of outflow. If that happens, the pressure inside the eye stays constant. If for any reason the rate of production is greater than the rate of outflow, that causes an increased pressure in this front chamber, the anterior chamber of the eye. The back part of the eye is filled with a jelly-like substance called the vitreous, and pressure in the front chamber of the eye causes pressure all the way back, puts pressure on the retina, on all these little blood vessels and nerves back here, and can start to cause nerve damage that causes you to start losing peripheral vision. And that's what glaucoma is this increased pressure that does damage to the back of the eye. And diabetics are a little more susceptible to that sort of thing. So it's definitely something that we want to check our diabetic patients for. And the most common form of glaucoma is open angle glaucoma. There is a type of glaucoma that's called closed angle glaucoma. That's where that angle actually closes down. With diabetics, we're concerned about the development of what's called neovascular glaucoma. Neovascular means new blood vessels. If new blood vessels start to grow, this happens in various parts of the body with diabetics. The existing blood vessels become damaged, and new blood vessels come in, little spider veins and that sort of thing come in. And if that happens in the angle of the eye where the fluid is supposed to drain out, there are membranes that are formed, and it starts to block the outflow of aqueous. And remember how I said the amount of fluid that comes into the eye should equal the amount that comes out. If anything blocks that outflow, just like a drain in a sink getting clogged, the eye is a closed system. A sink could overflow onto the floor. That's not going to happen in the eye. The pressure starts to build up if there's more fluid coming in than there is going out. And that's what glaucoma is an increased pressure like that. Because of these blood vessels being able to form in the angle and even in the iris with diabetics, there is the possibility of neovascular glaucoma, which is a very complicated form of glaucoma. And so that's definitely a concern for us with diabetics. So we thoroughly evaluate the eyes of our glaucoma patients, and glaucoma is only one of the things that we look for, but it's an important thing. Glaucoma can blind you, just like some of the other problems. Usually when eye doctors think of diabetic eye disease, we think of the retina right away. We think of diabetic retinopathy, and that's going to be something we discuss probably in the next video. And that's where the majority of our concern is in the retina, and there's lots of reasons to be concerned back there. But glaucoma is one of those things that we do concern ourselves with. And the pattern here, I started with the lens, and we've been in the front part of the eye. On the next video, we're going to move to the back of the eye, and things definitely can get serious. And in the back of the eye, in the retina, and those nerve tissues, and that'll be our next video. Thank you. Remember, live healthy, finish strong.